everyone. And in fact, please start. And I'm very happy to be here. This was the third year of my scientific committee specialists, everybody coming here, and I consider one of the best meetings. And I also did one year, I remember very well in the PHU. And thank several times for the governing council meeting. So again, I will allow him to still not able to share this. Hello. I think screen sharing, you have to allow. I make him sub co-host. Who's interested in retina here? Any of you here? Who's interested in retina? What is the problem?
On the retina at the top of the
I got it. Yeah. Yes. So sorry for everybody. I'm sorry we are 20 minutes delayed. That's why and which is significant 1970 along with 1974, O'Malley and Haynes sclerotomies, which he was also in India in 1995. Instruments were introduced. I'm glad we introduced first in India in 2004. And the acute intervention 25, 23, and 27 since 1984. So 25 gauge vitrectomy, created by small localized posterior hemorrhage, right, was a you can see my screen in the okay. So 27 gauge so that it will be a less inflammation, less postoperative discomfort, and early visual recovery. So 27 gauge vitreous cutter is the best device for membrane dissection in diabetic eyes because it can be easily inserted between membrane. Now with the proportional mode, you can even do it with 25 or 23 gauge. And an improved high-speed 27 gauge vitrectomy system offers anatomic success in patients with diabetic PID, similar to the 23 and 25 gauge. Surgical procedures are simplified and operating times are shortened with the 27 gauge system. The recent advances are stiffer instruments, wide-angle viewing system, wide-angle illuminating light pack, either using xenon, mercury, or even LED now, and chandelier illuminating optic probes, or one-step vertical incision trocar cannula instead of two-step angle sclerotomies, and self-clearing sclerotomy. So you do a beveled entry, and 27 gauge easily passes between the membrane and the retina. Wide-angle fundus viewing is the comparison. ultraviolet 25 gauge for a chemist so that and when we make it disposition, it increases, and in India we can afford that. So I'm glad for the Indian company, and then we have the various advanced backflash needle, the soft version, and also the since 15 years, and I came to the vision, counting finger, right, we had cataract changes and with SF6 with the card and visual prognosis. So you can see the cataract has been already playing the 23 gauge entry. So usually I make the cataract steps and then I start the and then using the which is using the actually sucking the blood and under the air now removing the nose around the arcade. This is a view through the wide angle observation system. Pictures separate and make sure that photo except the optic disc and the this is the post-operative diabetic retinopathy. On the left, you see the traction detachment, and post-surgery, all the membranes removed. And this is a PDR with the extra max. The right side shows the post-operative picture. The membrane is totally clear. This is again a severe so the idea combined traction and there is no leakage in the traction. You can see the so I do 3D students and postgraduates microscopic illumination from the microscope. I'm glad Dr. Deepak Mishra mentioned you are getting a 3D vitreoretinal surgery, 3D surgery here in 2 OTs, a computer which processes the input and output signals, and then a high definition display image, 3D glasses to view the display, and this is how the display is done. So you can also have the 3D viewing system and the mechanics, and that's the best part of the. And you can sit back and operate, which I never thought we can do that. See, you can see I'm sitting erect, but you can sit back and rest on the end. I have a hand rest, ankle rest, and you can see entire operation theater group can watch exactly what you're doing. So the only thing here is in the beginning, I think in 80s when we were operating, only the surgeon could see whatever you're doing, and the fellows like us when Banaras was operating, we could see, but not exactly the same as the surgeon during the assistant microscope. But we'll be holding the contact lens. Now we have the wide angle where you can see the wide angle there, where you don't need an assistant now. Everything can be adjusted by the foot switch of the both legs, both hands. That's why you have to be like Lord Shiva, like Natarajan, have 4 hands and so many multiple functions. And now everything is available in the microscope. And that's why I always tell you need both hands, both legs, both ears, both eyes, and the brain too. Because without that, nothing works. And that's where I think it's a digitally enhanced visualization, so you can play with the images and dynamic contrast. You can improve the brightness. You can. I think I'm still learning to edit those videos. Image quality is better than the traditional microscope. Digitally magnified, inverted image possible, but I'm
ऊपर बैठे हुए हैं पहले
every time I resident. No, I know they're on me. No, I agree. So this is a real-time responsiveness. There is a 28-second delay, but I think you practice that. Anything has a learning curve. But I, with my experience, I always tell my legs speak to the foot switch and my hands work with the, which is that's why we need the divine power, and that's why I come to Varanasi. the most I don't know how many of you are imbibing. I stopped near the Saraswati, which is their entrance of the BHU, and the goddess for learning. And so I'm having, our surgeons have not reported any difficulty with the learning technique. It's an advanced teaching tool. I think an institute like this should have. I'm glad, congratulations to Banaras Hindu University for the Regional Institute of Ophthalmology, where this will be a display of surgical field as seen exactly by the surgeon, the entire OT, so that now we don't have technology to transfer. I hope we can transfer between OTs. So more than one person can train simultaneously. Tissues or areas can be pointed out on the screen as against with the left, right, up, down direction. Simultaneous heads-up view by instructor and training improves the coordination during the surgery. And this is how the OT, say the view from my side and then the machine on the right. And so this is how we can operate, and then we can demonstrate. You can see exactly what you're seeing. We'll be able to, the students can see. And this is a PDR which I recorded through the SP system. I'm using it, and I do a beveled entry so that you can see the clarity is definitely much better. And then you clear the anterior post traction, and then remove the vitreous hemorrhage. So the 80s we were doing for hours together, and that's why we used to start operating at 8 in the morning and go until 1. And now we finish the surgery, and depends on the case. So if it's a simple vitreous hemorrhage, 10-15 minutes, and if it is a complicated case, 1 to 2 hours. Only PVRs take a lot of time, and but the whole idea is not the time. And here I'm using the under air the steroid to stain the uncut vitreous, and then I use the fluid air again, reinfuse the fluid, and just to check where the uncut vitreous is there, and accordingly I can see only an island of some vitreous is left behind. I'm now using the vitreous, the national brush to check that, and then clear all that debris so that all traction is relieved. And I'm using the high cutting and low suction so that I can work close to the retina. The idea is to totally free the retina from traction and do a pan as a photocoagulation, maybe 1,000 or 2,000 burns, depending on the most of the patients in India are not done laser. The reason is they somehow don't understand that if you're a diabetic, you don't have to wait for the vision to go down. You have to come to the doctor when the vision is normal. The problem is everybody wants to come late. So by the time the vitreous hemorrhage happens, there's no laser done. And then if they don't come in time, still they develop traction detachment. And you can imagine these sort of eyes can get 6 and 5 vision post-vitrectomy. I'm glad we are doing this from 84. So how many years? 37 years of vitrectomy now. So I'm glad I'm doing, I love to do surgery. And even though it's 37 years experience, but I feel like 18 only. So now you can see the eye is filled with gas, removed, so you don't have to suture. And many times, many of my friends from Europe and US want to say, how can you do a surgery without sutures? And I think I've done every surgery, not a single patient I've done suturing after I've started doing sutureless surgery. So you can ask me questions. Now everybody can be unmute yourself, or you can ask. Even otherwise, I will repeat the question. So whoever is listening in the next can. So you should ask some questions. So we have students all around here. I'm just rotating. All of you say hello. Yeah. So,
Professor,
yes.
there is a vitreoretinal fibrovascular membrane. It can be easily removed and even vision of the patients.
Yes, sir. So I never use the word easy. This is why I always tell, even a cataract surgery, I think you should make it complicated to the patient. The reason is it takes so much time for hand-eye coordination. I mean, I'm sure, which year you are? Third year. So you should know from first year to third year how easy or difficult. For me, it's easy, but for the patient and for other surgeons, it's difficult. So I think nowadays we can do, that's why earlier we do, it's better for the patient. But if the surgery, if there are membranes, I think all complicated, I never give up. Only thing is, in a diabetic eye, we need the patient to have PL, and we operate. In a trauma patient, even without PL, I operate.
Prognosis is much better now.
Yes, definitely. Yes. All of you should ask some questions. No? Any question? You should ask some question. That's a very good question. The way, I think the way you are asking question, the patients you have seen maybe are not satisfied.
No. That is not the case. If I think of
I think the problem is if the retinal detachment patient comes in, for example, the detachment happens and they report same day or next day, and the prognosis is 90% good, or maybe more. But the problem, the patient comes 1 month later, 3 months later, then they tell, for example, even to me, they will come and say, Dr. Natarajan, we have heard also, I mean, I'm operating 37 years. Many patients can't believe I look younger. 37 years back, operated patient also comes to me. Sometimes they tell me my father operated because they don't recognize me. So what I meant is that the patient, those days, the prognosis are very bad. And if the patient comes with traction detachment, with macula off for a few months, and you operate, the patient will be only 2/60 or 3/60. So that patient, when they get 3/60, according to me, the patient is grateful to me because he calls me a God. I'm not a God. I only pray God that he can vision. But for me, for him, I'm God because he's able to see his own food, his own partner or friend, relative, and also he can manage himself ambulatory vision because he can go to the toilet, he can go in a car, he can walk around without a stick. So that's what I think, according to me, the patient who has been given up by others, that's the reason I myself come and talk everywhere. Where whatever patient you feel nothing can be done, I think you should send him to me for a last chance. And if there's a chance, if I think I can operate. But vision is whatever you can call, whether it's nature or God. Some patients don't believe God. So okay, nature. But I am also not God. I'll do my best. If I have, for example, bad prognosis patient, I give 1%. What is the meaning of 1%? Tell me, what is the meaning? We operate 100 patients, only one patient can have anatomical success. So in retina, we have two problems, two success. One is anatomical success, second is functional success. So the problem is anatomical success question. And second, only when the retina is attached, or macula is attached, and how long the macula was detached is the reason for the poor vision. So even macula of detachment, literature says you can't get normal vision. And I am now analyzing, most of the patients have got a very good vision, 6/9 and 6 and all. And I think that's where you should practice the fine art of scleral buckling. Any other question? Any other question, sir? Thank you. Thank you all for the
Nice lecture.
Yes, anyhow.
Stimulated to be the student.
Yes. Yes. And congratulations for the Regional Institute of Ophthalmology, sir.
Thank you, sir.
Yes, thank you. So all the best. And I will be there for the online this thing. I have a same time another. Thank you, Deepak, for the. Just we are concluding. Thank you. Thank you all. Thank the BHU for the wonderful.